Good morning or good afternoon, wherever you are. I'm Grace Rubenstein, Editorial and Communications Director at HealthBegins. Welcome. Thank you so much for coming to this webinar on achieving liftoff on medical legal partnerships. It feels like if ever there was a topic right for its moment, it would be this topic at this moment. So perhaps that explains why so many hundreds of you have signed up to join us today. We have just an amazing lineup of speakers here to help. And Ellen, if we can go to the first slide, we will just run through a couple of housekeeping items as we get started. Next slide. The quick things to know are that this webinar is being recorded, and we will be sharing the recording with you via email after the webinar. All of your lines as participants should be on mute, but we really want this to be a dialogue, and we're going to be using the chat very actively. So any question that comes up as we're going through the presentations, please just drop it right in the chat. I'll be keeping my eye on the chat and making sure that the questions make their way to the panelists for the Q&A section. This is a 1-hour presentation, and it is hardly the end of the discussion. So we're going to be keeping the conversation going as we proceed on Twitter, as well as after we conclude today. You can see the handles and hashtag up there on the screen right now to keep the dialogue moving forward. In conclusion, we are all a community. We really believe that at HealthBegins, and as do our partners. So let's all please bring and share respect, curiosity, and joy in today's session. And it is now my pleasure and honor to introduce Ellen Lawton, Senior Fellow at HealthBegins and a real pioneer in the medical legal partnerships movement, your host for today. Ellen.
Great. Thank you so much, Grace, for getting us started, and welcome everybody. So excited for this conversation today and to hear from the leaders that we've assembled for this discussion. And so I'm just going to take a little moment here to ground us, first of all, with our amazing presenters who you'll get to hear from: Bethany Hamilton, co-director at the National Center for Medical Legal Partnership at George Washington University; Gerson Sorto, supervising attorney at the Medical Legal Community Partnerships Program, Neighborhood Legal Services of LA County; Anne Fabini, associate chief of staff at geriatrics at the San Francisco VA Medical Center; and then Lara Islehart, senior attorney, medical legal partnerships attorney at the Office of General Counsel in the Department of Veterans Affairs. So fortunate to have them with us and excited to hear their perspectives. Today's learning objectives are including the following. You're going to be able to list the core components of a medical legal partnership, describe the impact of MLP in a range of settings and populations with a focus on veterans, and then most, I think, importantly, identify policy and sustainability strategies at the federal and state level to grow MLP impact and scale. And we have a great team here to help us do that. Just briefly about HealthBegins, we are a national mission-driven consulting and training firm dedicated to improving care and the social and structural drivers of health equity. Manage my moving slides here. Our mission: we inspire and drive radical transformation in health equity by helping existing and emerging leaders in healthcare, public health, and the community to move upstream and improve the social and structural drivers of health equity for patients, communities, and society. And what do we mean by moving upstream? We help leaders and frontline caregivers to understand that moving upstream means continuously improving the social drivers of health and equity at all levels. And that means individual social needs, such as food insecurity, community level social determinants of health, such as food deserts, and then deeper structural determinants of health equity, such as redlining and structural racism. We work with leaders across sectors to translate this understanding into action with clear strategies, learning collaboratives, improvement campaigns, and place-based investment portfolios. That's what we mean by moving upstream. And that brings us to our topic today, medical legal partnership, which, as you'll hear, truly embodies the upstream approach to improving health equity. HealthBegins has a long history of advancing medical legal partnership practice, starting with our CEO, Rishi Manchanda, who's a family medicine physician and innovator who established several MLPs in health center and homeless veteran settings. I joined HealthBegins last year to help lead in tandem with the National Center for Medical Legal Partnership, training and TA activities for a new initiative with Kaiser Permanente to build MLP programs into the KP system with a focus on housing instability and eviction risk. And together we aim to create those conditions where all health organizations across the country can leverage legal aid services as a standard feature of how we respond to social needs, so we can improve the desperate, truly desperate circumstances that many of our communities are facing right now. MLPs have that potential, and so we're here today to share those insights of MLP leaders who are moving the dial in the field and across the country. So welcome to all of you. Looking forward to hearing from our speakers and to hearing from you all in the chat with your questions and comments and insights as well, because we know that there are likely many MLP practitioners, wannabes, and folks who are trying to accelerate their practice out there, and we want to hear from you. So let's dig in. Our first speaker, Bethany Hamilton, is the co-director of the National Center for MLP, an MLP and health policy expert, and she's going to kick us off with a high-level overview of medical legal partnership. Bethany?
Thanks, Ellen. Appreciate it. Good afternoon or good morning, everyone. It's great to be here. As Ellen mentioned, I will be going over the high-level overview. The way I'm going to talk about medical legal partnership is really about framing and then integrating legal care as healthcare. Let's go to the next slide. To frame this properly, let's click through some of these animations, make sure they show up. We're really talking about how to understand legal needs first within that SDOH framework that we know very well. One way to illustrate this is we know one social determinant of health factor is being in a food desert. So let's click through this and we'll see that how that translates is into social needs, such as a family living in a location with a food desert, having this unmet need for fresh produce. In some cases, if it's a positive version of that social determinant, that person is not in a food desert and they don't have an unmet need for fresh produce, right? But then some of these social needs we know and understand have legal underpinnings. So if that social need goes unmet, such as that family's need for fresh produce, and it's SNAP benefits that have been denied that would have given them access to that fresh produce that is needed, perhaps to control some sort of health condition, then that's where you may have legal services that can come into play to address that social need with the legal underpinning. So we set that as the...
I had left a...
Hi, Irene. We had someone go unmute and now they're back muted. All right, so back into the show. Let's go to the next slide. Now that we understand, right, how legal needs fit into the SDOH framework, let me just level set and make sure we all understand the definition of the traditional, the classic MLP approach. We define the medical legal partnership approach as an intervention, right? Because we know all of you, you're doing the screenings, you understand the SDOH factors and the needs, but you're looking for that intervention where you can bring together legal and healthcare professionals plus everyone in between in that social workspace, right? To collaborate and help those patients or clients, members of the community, really resolve those social, economic, and environmental and other factors that contribute to the health disparities that we see that are so pervasive and were exacerbated, especially during the pandemic. And they have that remedy in civil law. I want to pause for a moment and just note that, you know, this is the traditional definition of the approach where there's a remedy in civil law, but we are really enjoying seeing the growth and expansion of medical legal partnerships into other spaces. And it's really fascinating to see us go into the criminal justice space or something in between where MLPs are applying this approach. Let's go to the next slide. So where MLPs right now around the country and in the territories, we see them in various healthcare settings. You're going to hear from the VA medical center settings today, but we see explosive growth happening in additional spaces such as community health centers. And of course, the classic setting that we've seen and know well from where MLP started is in that hospital setting and other health systems. So we're estimating actually, around a little over 500 medical legal partnerships around the country. We see news every day about new MLPs starting, and hopefully we'll have some more accurate numbers along the way to give us a sense of what this really organic growth has led to. All right, next slide. The MLPs, no matter where they are, and no matter what, I highlighted healthcare partners, but I didn't highlight the legal partners, which also vary. But they all have some basic components. They all have a lawyer in residence, either in-house or that they've contracted with. And that contracted or that arrangement often comes about through an MOU, that formal agreement between the partnering organizations with regard to who they're going to target in terms of the population, what legal needs or social needs they're going to address, what are the resources they're really going to designate and then dedicate to this, how they're going to do the information sharing so that they go beyond just making a blanket referral and not knowing where that referral goes. How are you really going to exchange information? How are you going to train your multiple sector staff, all these professionals, on what it means to integrate legal services into your care delivery models? And then how are you going to staff it, right? We're not just talking about lawyers, we're talking about entire legal teams that include the paralegals. You have CHWs, and on the legal side, assistants, folks who are really doing the screenings and reaching out to the communities to really make these partnerships work. So the various MLP models around the country have these basic components. What are they getting done? When they've embedded lawyers onto the healthcare teams in that healthcare delivery model, they're doing the direct legal assistance, they're doing the trainings, they're looking at and effectuating clinical level changes. And then what we'll highlight some of today are those policy level changes that they're carrying out, all ultimately for the outcomes you see, just the high level bulleted outcomes you see on the screen: healthier patients and entire communities, creating a stronger healthcare workforce. And then finally, what we're really trying to address here is improving health equity and outcomes. All right, so I said I would highlight and dive a little bit deeper into the policy work that medical legal partnerships carry out. I'm happy to say and really tout this is that MLP is one of the only interventions that's able to really tackle those individual needs as well as underlying policies. So by doing the individual work, by doing the hotspotting, that's where MLPs are able to really detect the patterns and the trends in the community that may actually be better addressed through, or reveal that there's a policy level change that needs to be done. And we've seen a lot of this done in areas including the eviction crisis. We've seen some of this done related to utility needs or lead issues for children. Unsafe housing issues are often where this comes up, and MLPs have played an impactful change. What are some of the projects that MLPs engage in when it comes to policy work? They're using data and storytelling. We've seen, heard from, and engaged in some of that those storytelling efforts that are done before council members or policymakers. They're meeting with agency folks to really propose changes to everything from procedures or administrative aspects of some of the administrative barriers that are in the way of folks getting access to those benefits that they are entitled to. They're also meeting with those community stakeholders and decision makers. And then obviously, because we're talking about civil law remedies, they're challenging laws in the courts. They're doing the litigation. One great example that we, among the many examples that we like to talk about in the patients to policy work, I'll just highlight one of those today. It's from Whitman Walker Health in Washington, DC. Whitman Walker Health is one of the early pioneers in embedding lawyers into the healthcare teams. And this was done well over 30 years ago during the HIV/AIDS epidemic. So they early on understood and realized the value of bringing lawyers into the team. Whitman Walker Health has a truly fully integrated medical legal partnership approach. And in or around 2016, Platinum Care plans, which are really expensive plans, but they make the most sense for individuals with HIV in terms of cost sharing. There was a potential that those plans would have been eliminated from DC's marketplace, their exchange. And so by having that medical legal partnership and the relationship with DC's exchange and the providers, this medical legal partnership was able to effectuate a change that retained the platinum insurance plans for the individuals that they serve with chronic illnesses. And that ensured that thousands of patients maintained access to care, not just Whitman Walker's patients, by the way. This was a system-wide change that they were able to prevent from happening, the elimination of the platinum insurance plans, and that helped everyone throughout the community, not just their immediate patients. So this is just one example, right, of a patients to policy impact that an MLP had. But there are opportunities right now for MLPs to actually weigh in on really proposed investments in what they do to help expand, sustain, and sustain their work. So one of those opportunities I'll highlight, and then we'll just show in the slides that there's another opportunity, and there are others that we can highlight. But right now, HR 5241, which is really that Elder Justice Act reauthorization, is being proposed. This is the Linking Seniors to Needed Legal Services Act of 2021. It's in the Build Back Better Act. We're looking forward to hopefully that language and those dollars, about $500 million over 5 years, being retained to truly help not just expand the existing programs that have really been supporting linkages to legal services. Those are those elder justice and rights programs, but also new investments specifically in the MLP approach. So this would be money being appropriated to really pass down to the states that would be made available to various types of healthcare providers, and other types of grantees to carry out medical legal partnership work within the elder justice framework. This really builds upon some of that early work that we saw being done by those pioneers in the elder justice MLP space. And so it's really to their credit that we're able to see this type of very specific legislation addressing not just legal services, enhancing that, but also investing in the medical legal partnership approach. So on the next slide, I'll just note that there have been additional proposals to really help support the advancement of medical legal partnerships, such as the one on the screen for Veterans Medical Legal Partnership Act of 2021, similarly passing money down to the states. And this is, again, because of that great work that's been done by the VA to help advance legal clinics and medical legal partnerships that support veterans and address their needs around the country, particularly in terms of homelessness, unemployment, and other types of social needs with those legal underpinnings. Health centers, I know many of you are probably in the audience, and you know well that in 2014, there was a policy change, right, to Section 330 enabling services to really help advance and explicitly mention civil legal services as an enabling service. And so these are the sorts of policy changes and opportunities that we hope MLPs will continue to take advantage of so that they can, like Gerson will explain, advance their work on behalf of communities. So with that, I'm going to pass it back on to Ellen so we can hear from the remaining speakers.
Great, thank you so much, Bethany. Really appreciate the overview, and we'll turn it right over to Gerson Sorto, who's going to talk to us about his work in LA County. Gerson?
Thanks, Ellen, and very smooth segue, Bethany. I appreciate it. It's a pleasure to join everyone. I'm with you today to offer a case study about how we've implemented our partnership here in LA and to share some recommendations for MLPs moving forward. So next slide. Our work in my organization, Neighborhood Legal Services of Los Angeles County, are based here in LA, and the county covers nearly 5,000 square miles, and it's as diverse in geography as it is in its communities. And one of the key partners in ensuring healthcare access for LA residents is the LA County Department of Health Services. They operate the second largest health system in the nation, serving more than 600,000 unique patients each year through the network of hospitals and outpatient centers. And they just happen to be our medical partner. On the next slide, we'll see one of their initiatives, which is Whole Person Care Los Angeles. And through a Medicaid 1115 waiver, DHS funds this Whole Person Care program with the intention of targeting individuals with the highest needs in the most critical areas, including those that are unhoused, experiencing frequent hospitalizations and living through mental crisis. And clinicians and social workers, community health workers, and others directly support these patients to improve health outcomes. Through that work, these teams often identified legal barriers which encumbered their advocacy efforts and kept programs participants from achieving stability. And that's where our project was created in response to that particular need. The next slide, we'll see our partnership. So we were funded through the same Medicaid 1115 waiver as whole person care. And MLCPLA was initially charged with serving that whole person care population, along with patients at one clinical site in South Los Angeles, with MLSLA as the lead agency and in close partnership with LAFLA, MHAS, and Bethany Legal Services. Our core services include legal help for patients, curbside consults that we call requests for technical assistance, training, and then also systemic advocacy, in line with what Bethany shared with us a little bit earlier. And we add community to the MLP name just to call out the importance of the various communities we operate within, including the people we serve and the health systems that we partner with. So to meet these needs within the resources that we were initially provided, we developed a hybrid service delivery system centered around our case management system, Legal Server. As with all MLPs, training and engagement during that initial period was crucial. We developed comprehensive onboarding materials, a curriculum that helped us really engage with our partners, and something that continues today. And with support of one of our consultants, Lara Islehart, some of you might know, we set up an easy to use referral portal for CHWs to submit those referrals and requests for technical assistance. We also adapted that same system to collect data from our legal partners who were seeing DHS patients at different clinical sites. Housing this system within Legal Server allowed us to readily share case information between partners and also satisfy our data sharing and reporting obligations to the county and DHS. And I'm happy to say that since that initial pilot, we've grown significantly since that started in 2018. Today, our services are available to every patient throughout the DHS health system. We have legal staff assigned to DHS's 4 hospitals and 5 major comprehensive health clinic networks. And then we continue serving those whole person care patients through an electronic referral portal, and actually have extended that to other 3 clinic networks within DHS that weren't previously covered. So with that, I'd like to move on to a poll question for all of you. I know that there's lots of different folks engaged within the MLP space in the room, but for those of you that participate in the medical legal partnership, how is your legal system currently delivering services? You'll see a pop up on your screen and would appreciate your response. For us, MLCPLA, like many services at DHS, we transitioned to fully remote work during the pandemic. In July of this year, we began to physically reintegrate within the DHS sites. And based on feedback from patients and our clinical partners, we have also maintained remote services options for patients who still prefer that telelegal visit. So if we can close the poll, we'll see some responses as they're coming in. It looks like as they come in, the majority of you are actually still operating remotely, 55%, with about a third operating similar to us in this equal distribution of co-located and remote services. And that's interesting. I think that helps shape how we engage patients and how we move forward in our work. On the next slide, we'll see a comparison between legal problems we've encountered between our whole person care group and our DHS clinical site patients. To date, we've opened nearly 9,000 cases across all of MLCPLA, each one representing a legal issue for one client. So the time and engagement we spend with each client also varies greatly. An average case might be closed within about 4 hours, but legal partners regularly handle cases in immigration, housing, and family law, for example, that can require over 100 hours to resolve. During the pandemic, we also saw that the number of referrals and initially dropped, right in those initial months during the pandemic, but the number of cases per person, the complexity, and the urgency of those cases all increased. And these differences between whole person care and the clinical sites really help inform our outreach and focus. So with whole person care, we might offer training on traffic ticket advocacy or expungements while supporting staff at our clinical sites with tools for screening for public benefits programs. Patient need, location, and CHW support are all factors that impact the kinds of issues that are presenting at each one of our sites. And on the last slide, you'll see, one of the greatest challenges we faced, and I know that it's one that all of us in this call faced in one way or another, is reimagining our work during the pandemic. So in April and May of 2020, we saw a marked decrease in referrals, despite knowing that patients faced more barriers. And integration is such a key part of our medical legal community partnership. But how could we do that when we were physically separated from our partners and from our clients? Once our clinics were ready, we stepped up our outreach efforts by joining clinical case reviews, virtual grand rounds, and staff meetings to learn more about clinic and patient needs and to share more about our role in COVID recovery. One of the silver linings of the pandemic, I think, is having more logistically easy access to those meetings that we might not have had otherwise. We developed Know Your Rights informational materials for staff and patients and created additional referral workflows and developed easy to remember screening questions for staff. And then we also just created an ongoing webinar series offering key legal insights for DHS staff. So for example, this coming Monday, clinicians will learn how they can make the immigration process more accessible for patients and disabilities. To date, we've conducted 236 trainings and outreaches, reaching over 6,000 DHS staff and partners. And I attribute our ability to effectively scale up and even to respond to the pandemic in large part to our broad coalition of legal partners and also to the existence of our remote referral portals we had set up. When we quickly shifted to remote work, our case management system was already set up to electronically share data between partners, no matter where they were located. When one clinic received what is typically 2 months worth of referrals in 1 week, we all came together to offer support and really amplify that particular partner's bandwidth and cover those referrals. And I think most importantly for me is we each contribute our MLP knowledge, resources, and community connections in a true and meaningful partnership, something that one single organization couldn't do as easily. Moving on to sort of the policy piece, in 2022, CalAIM, or the California Advancing and Innovating Medi-Cal Initiative, is replacing the Whole Person Care Pilot. And CalAIM is DHCS's, Department of Healthcare Services, multi-year initiative bringing reform across numerous Medi-Cal systems for the ultimate goal of improving patient and population health. For MLCPs in California, it represents a unique advocacy opportunity to further expand the reach of MLPs and cement these essential services within the menu of benefits that Medi-Cal managed care plans are required to offer. Unfortunately, as it stands right now, the transition to CalAIM might actually target a narrower population than whole person care and might actually discontinue some crucial services like MLP. Through public comment, stakeholder work groups, and other strategies, we're advocating for legal services to be included within CalAIM and partnering with MLPs throughout the state to do so. This is going to be a long-term effort and so much more work remains. And so you'll see a photo there of a policy brief, and this was drafted in October 2020 and is still relevant today. It highlights the benefits and impact that projects like MLCPLA have on the DHS system and offers real concrete recommendations to expand our ability to serve an ever-growing number of patients in need of legal support. My last ask to you is to encourage you to take a look and hopefully you'll have some valuable lessons learned from there as well. And thank you for the opportunity.
Great, thank you so much, Gerson, and we'll be sharing those resources with you after the webinar. Our next presenter, Anne Fabini, some really exciting research that she's done on MLP and is going to share with you. Anne, take it away.
Thank you, Ellen. I am here to describe to you all what I would call a deeply engaged partnership between our local medical legal partnership for seniors and the San Francisco VA healthcare system. Next slide. Our program and its results were published in September in the New England Journal of Medicine Catalyst. The link to that article will be in the chat. So all the details are contained in the article, and I'd be delighted to have you all read it and spread the word. I'm just going to focus on the highlights. We, since 2015, have worked with our local medical legal partnership for seniors. That person initially was taking consults from our outpatient geriatrics clinic and our nursing home and our home-based primary care program. About 2 years ago, almost 3, we realized that we needed a higher level of collaboration to solve a particularly thorny problem, which essentially all VA medical centers in the country have. which is prolonged hospital stays of veterans who are really admitted and kept in the hospital for social reasons, not medical reasons. They get stuck in the hospital because they don't have a place to go for a variety of reasons. So we created what we call our transitions referral and coordination team, and the representatives of the various disciplines are listed here. So you can see it's a very broad interdisciplinary collaborative team, which includes our attorney from our medical legal partnership for seniors with UC Hastings Law School. Next slide, please. We decided that we needed to dissect our discharge process and better understand why it was that these veterans were getting stuck in the hospital. And when I say stuck in the hospital, I mean years, you know, way more than 100 days. We had veterans who were essentially living in the hospital. I think our longest length of stay was over 2 years. And we quickly discovered that obviously the medical stability of the patient had long since been achieved, and it was other elements of the veteran's life that was keeping him in the hospital. And I've used him deliberately because thus far all of our, all the patients who we have reviewed in our track team are men. So the members of this track team meet weekly for an hour. We receive referrals from the inpatient teams. And once we began to crack the inpatient nut, we started receiving more referrals from our emergency department, our primary care clinics, our homeless program, and the geriatrics clinic. So we realized that the easy part of figuring out when a veteran was ready to leave the hospital was the medical part, as I previously stated. And there are three then equally important areas or buckets that need to be addressed before a veteran can leave the hospital. And one is potential destinations, potential decision makers, and funding sources. And veterans often have an absence of one, two, or all three of these, which is what caused them to get stuck in the hospital. And as we shifted our focus from the inpatient setting to the outpatient setting, we were trying to do what HealthBegins focuses on, which is moving upstream. So let's start looking at the veterans who everyone's worried about and thinks, oh, this is not going to go well. He's going to wind up in the emergency department and then get admitted and get stuck. So as we gained expertise in how to get veterans out, we started moving upstream to help prevent veterans from getting in the first place. And that's actually, we just had our track team meeting 2 days ago for the week, and we were only discussing veterans who are not in the hospital and who are in the outpatient setting, but whose teams feel that they're going to fail imminently and they needed help from us. So this is the schematic. And again, this is all described in the New England Journal article. The next slide will show you in the darkened boxes where our medical legal partnership for seniors lawyer engages and does the work that healthcare providers and clinicians can't do. So Sarah Huffman, our collaborative lawyer, does capacity assessments, social assessments from a legal perspective, obviously, financial assessments, and financial capacity assessments. And she has been critical in identifying potential decision makers for patients, which is often where they get hung up. Next slide, please. So the process challenges included delayed SNF placement due to time spent verifying or accessing funds for Medi-Cal and other benefits, and an enormous amount of confusion about the need for or the role of the public guardian's office. And we have many fewer patients who we are referring to the PGO for conservatorship as a result. Next slide, please. So what we've learned, that's implementation of a standardized process for reviewing the need for probate conservatorship. Again, we haven't published this, but we have many, many fewer patients who are now referring for conservatorship because those were some of the longest stays, veterans waiting for a conservator. We use the geriatrics inpatient consultation service for capacity assessments in an attempt to standardize that work. We actually have a relationship with our public guardian office, which has really served us extremely well. Our track team is a forum for discussing challenging ethical issues and moral distress. One thing we've really learned is that sharing uncertainty and sharing distress about the future of a patient where people are, about whom people are worried, really allows all of us to think more clearly about what's best for the veteran. And then we engage in group decision-making about how to best engage family members in constructive problem solving around discharge plans. And so we've really become a learning institution, and we've been able to shift our focus from inpatient to outpatient because our inpatient colleagues have learned with us about how to better identify and manage these patients. So we really are working upstream, and this is the diagram that shows you our results. And again, this is in the published article. The link is in the chat. Thank you, Ellen. Back to you.
Thank you, Anne. Appreciate that insight, recommend the article. And now we're going to turn to our final speaker, Lara Islehart from the VA. And I am having a hard time getting to our slides. Oh, wait, I didn't go through the, sorry, animations there. Apologies, Anne.
No problem.
Lara, welcome.
Thank you, Ellen, and thank you for everyone for joining us. Ellen, you can turn to my first slide. My name is Lara Islehart, and I'm an attorney in the Office of General Counsel at VA, where I focus on medical legal partnerships, surprise, surprise, given my presence here. And actually, I'd like to note it's a new position that VA established earlier this year to focus on MLPs as a priority for the agency. And I'm going to give kind of a more broad overview of what VA is doing in this space and how we are working on integrating legal services with within our healthcare system and some new opportunities on the horizon. So Ellen, next slide. Thank you. So what do we know about veterans' legal needs? We know actually quite a bit. We know that they have extensive civil legal issues that can affect their health, housing, and if left unaddressed, can increase their risk for suicide. And actually VA does a survey each year that it's called the Challenge Survey. And it actually finds that at least 5 of the top 10 unmet needs of veterans are actually legal in nature. So some of them are very straight up legal assistance for housing eviction issues, legal assistance for child custody and family law. Some of them are more attenuated, such as revoked driver's licenses that need restoration. And that can have a direct impact actually on a veteran's ability to access healthcare at the VA or obtain a job to have an income stream to be able to maintain their housing. So these legal needs go far and wide. And thank you, Ellen. Next slide. And what do we do? What do we do about this impact of veterans' legal needs? And we see that VA research, we know that it can increase the risk for suicide. And the numbers are right here. And this is even after accounting for mental health diagnoses, that when veterans have legal problems, they have this 86% increased risk for ideation and 57% to actually attempt suicide. And this study actually found that these social determinants of health, legal needs as a social determinant of health, are as relevant as medical factors for this study where they looked at how it related to suicide. So it's really significant to note that link. And secondly, we know that legal services, when provided to veterans through MLPs with VA, can actually improve their housing stability, their mental health, and decrease their symptoms of PTSD, as well as reduce their spending on substance use. So I just want to note that, what is VA doing with this information? We have really worked hard to spread our presence through MLPs throughout the country. And this is a good visual to show you. We have over 165 legal clinics and about 32 medical legal partnerships. And they are now guided by a new directive. It's VHA Directive 1510, which establishes medical legal partnerships and encourages VA clinicians to establish them as VHA policy. So I think that is significant. And I do want to note also, if Assem could, put in the chat a link to where all of these legal clinics are and the VA clinicians who are the contact and the legal providers we work with is in that link right there. That PDF lists all of our MLPs and legal clinics. Next slide, please, Ellen. So what have we learned? So we have grown quite a bit in the past several years. We started out with just a few MLPs and just, a handful of legal clinics. And we've grown quite exponentially based on need and really, I think, just grassroots passion for this amongst legal providers and VA. And so we've learned that some of the best practices include a lot of what Anne kind of mentioned earlier is this kind of close collaboration, to have a designated process for the VA healthcare team to actually screen for and learn how to identify potential legal issues that are affecting the veteran's health and to provide that appropriate referral. We also want to see, it's most consistent to have a legal clinic staff that is trained on VA resources as well. So, and to be able to be culturally competent in the space of military and veterans population. And of course, there is a need for close communication that hopefully would be established through a very clear MOU. And I do want to note that VHA directive, I mentioned 1510, which was just published a couple of weeks ago, has a template MOU, which I think is quite strong to lay the groundwork for these best practices. Next slide, Ellen. And then I just wanted to mention a couple of new authorities VA has, which is quite novel, that Congress enacted a couple of laws early this year that gives VA authority to make grants for organizations to provide legal services to veterans. And the first, one of them focuses on homeless veterans and those at risk of homelessness. And the second one focuses on a more broad population, but these are both two independent authorities that Congress has handed VA to fund grants for legal services. And so we are actively working on implementing these through rulemaking right now. And then finally, I just wanted to mention that we also, next slide, Ellen, please. Thank you. Have our SSVF program, which stands for Supportive Services for Veteran Families. And through the American Rescue Act, we actually have funds through that program to fund legal services specifically. That was expanded very strongly in for FY22 funding for grantees of that program. And so I think these grantees have been specifically trained. I've worked with them on MLPs and the value that working with VA clinicians and legal services closely has potentially, to improve the services they can provide to these veteran families. So with that, I want to thank everyone, and I will hand it back to you, Ellen.
Great, thank you so much, Lara, and thanks to all of our speakers. And we've got some questions coming in that, so we're ready to, I want to congratulate my speakers for moving so quickly through the amazing content that we have. And to go ahead, and I'm going to share some questions with each of the speakers and get your reactions to. We're going to start sort of broadly what we're hearing, and the questions that we're getting are the applicability of medical legal partnership to a range of different populations. We had a question about MLP services in the maternal child health space or in the childcare space. A question about adult protective services and medical legal partnership. So I wonder if each of you could just, starting with Bethany and then down the line, Gerson and Lara and Anne, to just comment on MLP practice depending on population and where there are changes, things to think about, where there's activity, et cetera. Bethany, you want to kick it off?
Sure. So I'll say this, the MLPs around the country, if you've seen one, you've only seen one. And so, some of the questions, it sounds like Ellen in the chat, were asking, are there MLPs basically doing, the work in those particular areas? I can safely say yes. I would bet my personal dollar in my pocket on it, such as maternal and child health. I believe on one of the slides that Gerson even shared, there was an example of perinatal MLP work that's being done in LA County. Same thing, you know, across the country. In DC, brand new perinatal MLP just was recently launched earlier this year, if not late last year, with a study attached to it. So the work is ongoing in several areas. That is the point of that slide I showed about the basic components and really deciding what social needs you're going to address, which populations you may specifically focus on. I really appreciate Dee Dee's comment in the chat as well, by the way, about how we talk about this and the populations and the people. And you address that within, I see Alexander mentioning an MOU. Those are some the sorts of things that you would address in an MOU, but they're MLPs. Yeah, safely saying that they do work in all of those areas.
Great. Gerson, thoughts on that in terms
of?
Yeah,
no, I totally agree. I think, you know, one of our partners actually, Mental Health Advocacy Services, has a partnership focused just on prenatal healthcare and mental health services within the Department of Health Services. And again, definitely appreciate the recommendations in the chat about language. So there is a program called Mama's Neighborhood, and their focus is on first-time mothers and mothers of multiple children, or folks that are going through other barriers throughout their prenatal term. And for me, I'll say, you know, one of the benefits of this project with DHS, and if someone was looking to engage in the MLP space in this, is I'd say try to find a partner that's already doing this work that just doesn't include the legal aspect of it. Because Mama's Neighborhood does so much of the supportive advocacy and engages with them in a very impactful way. And then we're able to come in and then learn from our Mama's Neighborhood partners about how to engage with patients, and then be able to support our patients in that program effectively.
Thanks, Gerson. And I'm going to go to Anne because your article, I thought, really highlighted in terms of the applicability of MLP. It talked about how the meeting was the intervention, and that actually could have applicability no matter what the population that you're working with, that the meeting and coming together of the different sectors is the intervention. Do you want to say a little bit there? Anne, you're on mute.
Thank you, Ellen. We, the clinicians within the healthcare system, have learned an enormous amount from our legal colleagues, and realized long ago that because doctors and healthcare providers are the only professionals that a veteran can come to without getting a bill, that they bring legal problems to the healthcare system. And it was really our partner who helped us better understand how to articulate those problems, because we, like our patients, have low legal literacy ourselves. And so learning how to articulate and explicate what's a legal problem, and then engage in the problem solving with Sarah, our lawyer, so that we all were learning together, and then could take that knowledge to the next patient without necessarily needing Sarah's direct expertise. It has, yeah, that's been the intervention.
Great, thanks, Anne. And I'm gonna bring in Lara on this, but I'm also seeing in the chat lots of questions about kind of how do you set up an MLP and what are the basic foundations. And the National Center for Medical Legal Partnership has an amazing health center focused toolkit that has all the basics in it, lots and lots of resources. Let's put a link to the website in the chat for folks. But Lara, you crossed this Rubicon in the VA when you were looking at sort of traditional referral networks, you know, partially integrated MLP programs, and then fully integrated. Do you want to say a little bit about that for the audience?
Yeah, so you're right, Ellen. VA has sort of a pretty broad spectrum of legal clinics and MLPs. So we have fully, I would say, you know, fully formed MLPs where VA clinicians work very closely with the attorneys. There's that cross-training, there's that collaboration, there's those meetings that Anne talked about, and share that information appropriately. And then we have some more that are kind of scaled back or maybe could evolve into an MLP. So many more of them are legal clinics of that 165 number. And those are more of maybe a warm handoff referral where the legal provider is available every week, but they're not as closely collaborating with the clinician as maybe they could be. And sometimes that's just a capacity issue on both sides or either side. But I think that, one of the benefits VA has, I think, is a diversity of locations and levels of facility. We have large medical centers. We have very small vet centers and CBOCs, which are community-based clinics. And oftentimes in the smaller clinics, there's more latitude for exploring an MLP because it's a smaller, more sort of in touch community of clinicians and attorneys. And I did just want to say that, that we also see one MLP, you've seen one MLP in VA, you've seen one, because many of them have specific populations that I think it's important to note, to ask the healthcare side, well, what are your needs specifically in which population? And VA has a variety of elder, veteran MLPs and some women veteran focused, as well as even different periods of wartime, OEF, IEF focused MLPs, et cetera.
Great. Thanks, Lara. We got another question in the chat that I want to put out to anyone on the panel, all of you, if you want to respond, is how you see prevention in MLPs addressing social determinants. Talk about the framing and action around prevention as opposed to downstream interventions. So anybody who wants to hop in there.
I'll just start with this and just note that, this is where we see some of that patients to policy work particularly helpful, as opposed to doing just referrals or sticking to your silos, right, without an MLP. By having this partnership in place, you're looking across the silos and systems at various databases, the clients, the patients, that everyone's serving, to be able to do some of that hot spotting. And by hot spotting, right, through that, say, one MLP clients or patients case, you are, like the example I talked about earlier, able to effectuate a policy level change or an administrative change that can help an entire community and perhaps prevent an issue from coming up for someone else in that community down the road, right? And it could be preventing someone from ending up in an ER or just preventing someone from needing the MLP services. So that's just the quick example, but we're seeing even some really cool work happening in the violence prevention space that several hospitals have taken on. Some really innovative work starting to cross over into violence prevention, criminal justice, to prevent the health harming civil legal needs that MLPs have worked on traditionally.
Great. Anybody else want to comment on that, Gerson?
Yeah, I totally agree with Bethany's point. And I'll say, we've also are trying to figure out how do we affirmatively reach out to patients before they even know that they have a legal need to come to us with. And a couple of our sites, we're actually going to be piloting a secondary legal screening on top of a food insecurity screening. So food insecurity screenings are already happening, and we expect that patients that stream positive or food insecurity are going to have unresolved legal barriers, and we're trying to reach them before they even know that they have a problem and before that they know that we're a resource. So we'll see how that goes. Yeah,
and Ellen, I would just add to that our biggest discovery is that everybody, no matter how little money you make, needs a financial decision maker. Even if it's only your $800 a month Social Security check, you still need a financial decision maker that you name.
Got it. Great. Thank you. I have another question, again, for anyone on the panel, because this is a core component of medical legal partnership practice. Well, it actually comprises two core components, and that is around kind of the principles of good communication between legal and healthcare team members. And I think that is everything from training and education. You talked a lot about that, Gerson, but also the complexities of information sharing that we stumble on and sometimes overly complicate and sometimes underestimate. So if you want to talk a little bit about that and why it's such an important feature of MLP practice. Anybody want to hop in there? Or I can call on people.
That's a great one for the practitioners.
There you go.
I can start off. I mean, I think it is like you mentioned, such a crucial point. I think for us, it's been an ever evolving one. one of the, I think, in addition to, the engagement, face-to-face or even teams, right, in meetings and having that space, the data sharing component is so important. And one of the things we're still working on with our partners, with healthcare partners, is having us have more meaningful access to the EHR, being able to dive in directly and put in a note, read notes from clinicians and others. We're using other systems to try to circumvent that, but it's not as efficient. So I think to the extent that that can be built in early on, I think that goes such a long way.
Great, thanks, Gerson. Anybody else want to comment on that? I have one more question after this, so.
Yeah, I would just say briefly that really developing a shared understanding that lawyers have their own language, healthcare providers have their own language. They'll never be completely merged, but to be able to communicate in ways that we can understand each other takes time and the building of relationships. And for us, it was really face-to-face in the same room at the same table that really worked.
Great, thanks, Anne. And again, shout out to the National Center with tons of resources on navigating some of these challenges between toolkits and issue briefs, one in particular on privacy and information sharing that I think will be super helpful. Screening tools as well to identify legal needs. There's a whole issue brief series on screening on the National Center. But here with our last few minutes, I want to throw out to all of you, and it'll give you a chance to talk about the really exciting news out of the White House today, if you choose to, is how are we paying for this, right? Lara referenced some legislation, Bethany referenced some federal legislation that has the opportunity for payment. Gerson talked about the funding mechanisms. How are we paying for this? Anne generated the data that should account for an investment because of the cost savings. Thoughts or comments?
We're going to have to prove our value. And I think you all have done so already. I know that sounds like it's not a direct question, right? Because the MLPs that are around the country can show their funding pie, and it varies, often starting with philanthropic investments to help start it up and then building into that more reimbursement space, breaking into the Medicaid managed care space where they're using the 1115 waivers like Gerson talked about with the whole person waiver in LA County in Southern California. These new investments specifically for appropriations, they are for very specific purposes. And so to continue to advance these opportunities, take those data in the different data sets and silos that you all are gathering, analyze it, tell the stories. That's how we're going to pay for it. I know that doesn't sound like a direct, that's my soapbox. That's how we're going to pay for it.
Got it. Great. Anybody else?
I'd like to add one piece. I agree with everything Bethany said. And I think also in terms of value, for us, we've been trying to redefine and really push the envelope of what's considered valuable. Looking at, for example, clinicians' job satisfactions at a time when the pandemic has already stressed everyone to the max, by engaging with us, and they can operate at the top of their license and really focus on clinical care. And that's something that we're trying to also quantify and measure in our project.
Thanks, Gerson. Anne, can you testify to that? Given
Absolutely. Well, our MLPS colleagues were able to go to the city and county of San Francisco and show that the work we've done had decreased the burden on their PGO office and the number of applicants for guardianship. And so our lawyer is funded through the city and county of San Francisco.
Great. Lara, you're going to get the last word here because of the great policy changes that you've helped to usher in there at the VA.
Well, I did want to mention, thank you for reminding me, that it is exciting to note that the White House and Department of Justice announced and released a report on their first report of a reinvigorated interagency legal aid roundtable, and also reestablished the DOJ Office for Access to Justice. And I believe there was if the Sem could drop it in the chat again, the link to the press release. That report, which was released just, I believe, last night, contains strong statements about the value of MLPs, including our very own Secretary McDonough noting how important VA's medical legal partnerships are for increasing access to justice and healthcare as well. So I hope you have a chance to check that out. It's an important, I think, thing to note that our administration is doing that.
Absolutely. Thank you, Lara, for that. Huge milestones across the board. So much gratitude for each of you and your leadership and your contributions to this movement, and really grateful to the entire audience today for your questions, for your engagement, and stay tuned for next steps, and you'll be hearing from us. Grace, do you want to take us out?
Yeah, that was just such a rich discussion. A couple last notes. We will be sending out the recording to all of you who registered, along with, somebody asked for the resources and links that were cited in the chat. We'll be happy to drop those into that email as well. Along with a quick survey about your thoughts on this webinar. We always want to learn from you what more we can do to help you along in your journey. So we'd appreciate you taking a minute to fill that out. Finally, this conversation continues. So you can see our handle there for Twitter, Facebook, and LinkedIn. Let us keep the conversation going, and all of us keep growing and making a difference in this direction. Thank you so much, and we'll see you on our next webinar.
Great, thank you. And round of applause, virtual applause for Anne and Lara and Bethany and Gerson. Thank you so much.